Okay, we got it. The goal today is to go over the basics of VV ECMO and talk a little about troubleshooting, particularly in this era of coronavirus and the fact that a lot of us in different ICUs may be pulled to manage some of these patients. So I want to go over some of the basic considerations. I have no disclosures. So basics. What is VV ECMO? So the best way to think of veno-venous ECMO is lung replacement. It does the same things your lungs do. It can oxygenate blood, it can remove CO2. It does not provide any significant cardiovascular support and doesn't treat shock. The only time that VV ECMO affects blood pressure is if you're so acidotic from hypoxia and hypoxemia that by fixing those settings, you recover your hemodynamics. If a patient is suffering from hypoxia who responds to intubation and recovers their blood pressure. But if someone's principal problem is shock, then VV ECMO is usually not the intervention. The way it works is pretty straightforward. It's to drain blood from the blood, oxygenate the blood, and remove CO2 to return it to the venous system. Effectively, you're going to pre-oxygenate, pre-ventilate the blood prior to it goes to the pulmonary circulation. So unlike a normal body where the pulmonary artery contains very deoxygenated blood, blood's already oxygenated. Arterial blood will look just like systemic arterial blood. There are several important components of cannula. There's the catheter that drain the blood. There's the pump, oxygenator, and the cannula.
Hey, Jerome, I'm sorry to interrupt.
What's up?
If you have the opportunity, did you create this meeting?
I did, yeah.
Can you just mute all? Because everyone that keeps on signing in,
Sure.
it's not muted.
How to do that?
And then we can't hear you.
Yeah, no, sorry, Jennifer. I just don't know how to do that. Let me see if I figure it out.
Does anyone who's on know how to do that?
There's a way.
It has to be the host of the meeting.
Go to participants, and then you should be able to mute all. It's in the top part of your screen.
Okay,
because you're sharing screen.
Sorry, guys. You're all about to be muted. Bye-bye. Okay. You're muted. Okay. So the drainage cannula, the pump, the membrane oxygenator, and the return cannula. The drainage cannula serves to drain, as you expect, deoxygenated venous blood. It's usually the larger cannula because based on flow characteristics, it's harder to drain blood than it is to return blood based on fluid mechanics. It's usually located in the IVC, and it's a larger cannula. The common sizes we use are 22, 23, 25 French, or 23, 25, what we call dual stage cannula. All dual stage means is that the cannula is tapered, so that the end of it is 23 French, but the midpoint is 25 French. So the hole in the vein is still a 25 French, but the tapered drainage allows for it to maybe get to a smaller vessel. With coronavirus patients, we're seeing need for almost total pulmonary support, so we're going to use the biggest cannulas we can. So our common thing is going to be 25 French cannulas for venous drainage because most of these patients are men. Next up, we have the pump, which is going to drain from the drainage cannula. There's a centrifugal pump that's then going to pump blood to the oxygenator. This is one example of the pump right there. It goes to the oxygenator. This is the cardio help. So blood's going to go in from the pump. It's going to get oxygenated and then return back to the body. It's also connected to a heat exchanger, so it's able to set a body temperature. So you're able to control the patient's body temperature pretty effectively with ECMO. There's some other ports here as well that are important for troubleshooting. The return cannula is the arterial cannula. It sits usually in the SVC in this case. It returns oxygenated blood. We refer to it as the arterial cannula. Fun fact about ECMO is very few components of ECMO are actually FDA approved for ECMO. They're repurposed from bypass. So we refer to the oxygenated blood return cannula as the arterial cannula because all the connections on the ECMO circuit are going to be labeled arterial. So we don't want someone to get confused. The most common sizes are 15, 17, and 19 French. We have been planning to use predominantly 19 French cannulas in the neck, again, to optimize flow as best we can. There are three main parameters you can control on an ECMO circuit: the RPMs, the FDO2, or the fraction of delivered oxygen going to the oxygenator, and the sweep. The way to think about this, your RPMs control flow. The more RPMs, the more flow to a point at the expense of more cell lysis. FDO2 refers to how much the blood's oxygenated, just like on the vent. This is like your FiO2 on a ventilator. And sweep is just like your minute ventilation. The higher the sweep, the more CO2 is removed from the oxygenator. Of note, just like on a ventilator, if you have zero sweep, the oxygenator is not doing anything. Just like if your FiO2 is 100%, but you have no gas flow, no oxygen is getting to the patient. It's the same idea. There are several different configurations to use. The overall goal, though, is to drain deoxygenated blood and return oxygenated blood. So you need is enough separation between these two cannulae to prevent recirculation, which is the phenomenon where blood, rather than going through the heart, simply circulates around the ECMO circuit. The most common configurations in the United States involve draining the IVC and returning to the SVC. When this epidemic is behind us, we can have an advanced lecture talking about why you might want to invert that configuration, but it's beyond the scope of this lecture. So here's probably the most common and classic approach. This is femoral internal jugular. We drain from the femoral vein with a cannula that approaches the heart and return for the right internal jugular, the cannula that approaches the heart from the SVC. Other possibilities are femoral-femoral. This was more common historically when pre-ultrasound, when the risk of sticking the IJ was higher, and there was some concern of inability to safely cannulate the internal jugular vein. And then we have the dual stage internal jugular cannula, which shares two cannula and one large cannula, allowing for a single device in the patient. In this current era, our most common configuration is femoral internal jugular for three reasons. It's fast. It's the most reliable to place without any sort of imaging guidance, which you do not reliably have. And you can sustain very high flow rates this way. Fem and the dual stage cannula require usually fluoroscopy and or transesophageal echocardiography to safely place the cannula. And so we've kind of made the executive decision that barring special circumstances, we won't offer those configurations because it requires more equipment and people in the room and trying to minimize exposure. So what is the cannulation process? I want to go through this so everyone has an idea of what it takes to go on ECMO. So the first thing you're going to do is you're going to obtain venous access in the femoral vein. The right is always preferred. People think of the femoral veins as interchangeable, but just like the neck, the right femoral vein is a straighter shot to the heart. The left femoral vein takes a more tortuous route. While it usually doesn't matter, similar to the internal jugular configuration, it can be more difficult to access the heart from the left femoral vein, so the right is preferable. If we are very worried about someone's hemodynamic stability, or we worry they may even arrest during cannulation for VV ECMO, we will often start by placing a femoral arterial line as well, so we can rapidly convert to VA ECMO if needed. In this case, we're trying to avoid doing that because if the patient's been intermittently prone, that's going to be another cannula that's going to be difficult to prone. You then obtain access to the right internal jugular vein. We have used the left internal jugular and the left subclavian, but always in the setting of imaging guidance. The concern is that imaging guidance is we don't have great wire definition, so right IJ is our by far preferred access site. We ensure wires pass easily from the internal jugular and femoral site. The goal would be to get the wire from the IJ into the SVC down to the IVC, and then the goal to get the femoral wire from the IVC into the SVC. Again, without any kind of imaging guidance, this is done by feel, so you have to have some confidence that your wire feels normal going smoothly. And you can consider using a stiffer wire in the femoral site. I bring this up because you'll see people ask for a super stiff wire, which is a much stiffer wire than normal, allowing for easier dilation and passage of large cannulae. I will caution you, though, that this same stiff wire will easily perforate the vessel and can lead to a lot of complications, which we're, again, trying to avoid. So please don't ever use a stiff wire from the IJ, and really think about stiff wire use if you don't have any imaging guidance. You're next going to give heparin at 100 units per kilogram, same dose used for carotids. For whatever reason, we kind of made up 100 units per kilo as our go-to dose for everything. You're going to draw an ACT at 3 minutes if possible to ensure adequate heparinization with a goal ACT of around 200 to 250. You then serially dilate Sellinger technique to place cannulae in the neck and groin. You're going to take the lines into the field, divide the lines, attach the femoral cannula, attach the IJ cannula. You can attach them in either order or in parallel. It's usually easier to attach the femoral cannula, and so we use that first because the IJ cannula usually takes a little more two people to hold it because it kinks. We're going to have a checklist to initiate ECMO. We'll secure the lines, initiate ECMO at slow flow rates, and go up from there. And then once everything's stable, we'll get chest and abdominal x-rays to confirm cannula position. So troubleshooting, which is where as intensivists and anesthesiologists, I think you're going to come into play. So either you're in the operating room with this patient, a bedside procedure, or dealing with them in the ICU. So you have hypoxia following initiation. This is usually 10 to 30 minutes after initiation of ECMO. Before this current era, what this would usually happen is when the senior cannulation physicians have left the room, the junior residents are in the room suturing the cannulas in place, and now we're hypoxic. So what happened? Most likely problem is recirculation, but we should go through what else it could be. So one, the flow. The worse your lungs, the closer the flow needs to be to the cardiac output. If you can hit 70% of your cardiac output on VV ECMO, your arterial sat should be about 89 to 90%, regardless of any pulmonary contribution. This will then allow you to basically fully support the patient. So if your flow is only 2 liters and you think your cardiac output is 10 liters, then you're clearly nowhere near where you need to be, and that's why you're hypoxic. Second problem, membrane problem. Is your oxygenator working? Did they inadvertently give you a pediatric membrane, which can happen? Is there a defect in the oxygenator? Rare. Quality control issues, though, have abounded at the McKay company, which is why we have a shortage of equipment. So it may be the oxygenator is not working. So you should look for what we call color change. Does the blood draining look dark, or the blood coming back look red? And then we can look at the oxygenation of the 2 cannulas. So effectively, the drainage blood should be very deoxygenated. We call it the SDO2, should be deoxygenated, the drainage O2. And the post should be very oxygenated, should be close to 100%. If you're really not sure, you can draw a gas pre and post oxygenator. And the post oxygenator gas should have a PaO2 300-400 range because it's very efficient oxygenation. Most likely what's happening here is what we call something known as recirculation, which is blood is mixing together. And this is, again, where blood is circling around the pump, but not effectively getting to the heart. So oxygenation of blood, while efficient in the sense of oxygenation of the contained circuit, is not effective. There are 2 main reasons for this. In our coronavirus patients, this is most likely because the cannula are too close together. We're pushing these cannula in blindly, and we're intentionally putting them in deep because it's much easier to withdraw the cannula than it is to advance it again later. Usually it's the femoral cannula. The IJ cannula is only about 16, 18 centimeters long, and most of these patients are men. And as you well know, a 16 centimeter IJ usually does not even reach the right atrium. So usually it's the femoral cannulas in too deep. The other phenomenon could be is the cardiac output is too poor. This doesn't often present as hypoxia necessarily, but it can also lead to significant recirculation. And this means that your cardiac output is so low that your ECMO is able to easily oxygenate all the blood, but a large proportion is not going through the heart. And this person needs to be converted to VA ECMO. Again, this has not been seen early on in coronavirus. Next up comes evolving hypoxemia. All right, this is something, again, that will bug you. We're seeing reports from Iran and China, 9 to 14 days average circuit run time for coronavirus. This is telling us that we need to be thinking of kind of long-term ECMO complications. A good rule of thumb on any ECMO circuit is you're given about 4 days of free time, okay? Most circuit complications, barring cannulation issues, don't crop up for the first 3 or 4 days. Come day 4, you start seeing the issues. This is often going to present as stable RPM, stable flows, and your hypoxia is getting worse. So is it the membrane? So again, check your pre and post gases and saturations. Something called the delta pressure, which is the pressure drop across the membrane, that should be less than 50. Over 100 is concerning. If it's rapidly been rising, we worry, is there thrombus on the oxygenator? Look for thrombus. These patients are on isolation. People are not vigorously scanning the oxygenator every 20 minutes like we might do up on Blake 8 or in normal situations. So people could be missing thrombus. The oxygenator is not 100% visible. 4 days is a little bit early for a thrombus if you're not having trouble with anticoagulation, but it's possible. Have the cannula position migrated? We're minimizing x-rays in these patients. We're not getting daily point of care ultrasounds. Have the cannula moved? We should make sure they haven't moved. Have we changed our ventilation parameters? Maybe we were sitting before in a PEEP of 14 with nitric and some pressure support, and now we've dropped even lower tidal volumes. So maybe we've made our lungs contribute even less. Finally, assuming all these things have not changed, the question is then look at our SDO2. If it's high, draining already oxygenated blood, then you're having recirculation. If it's low, you drain deoxygenated blood, then the ECMO is working appropriately, but it's not enough ECMO. It's almost always sepsis, unfortunately. You have an increase in cardiac output and oxygen consumption. Because of that heat-moisture exchanger in the ECMO circuit, you rarely have a fever. And again, as I mentioned, in the absence of even any lung contribution, as long as you hit 70% of your cardiac output, you can fully support an adult on VV ECMO. So you can increase the flow to compensate. The oxygenator is only rated for 7 liters of flow. So if your cardiac output exceeds 10 liters, I can't do that. You can give fluids, which will help blood pressure and things like that and allow you to flow more in the ECMO circuit. at the expense in sepsis of also further increasing the cardiac output, which is not great. So we treat sepsis like we always do, norepinephrine and antibiotics. There's case reports of trying to give esmolol or diltiazem, and you imagine by reducing the cardiac output, we're going to improve the flow matching of the VV ECMO circuit. However, in ECMO, you're often on significant low SVR state and need a high cardiac output to maintain adequate oxygen delivery. So you have to balance this here. So I think you're going to end up on some combination of norepinephrine, diltiazem, esmolol. Esmolol being the most attractive agent because there's some thought that beta protection of the heart may be helpful in sepsis. And then in extreme resorts, what we can do is we can paralyze and cool the patient to reduce oxygen consumption. We can even convert them to VA ECMO and intentionally put the patient to heart failure with esmolol in order to take over the flow support of the patient. Again, that's a Hail Mary approach and probably would not be offered to someone in coronavirus. Next problem on ECMO that comes up from time to time. So decreasing circuit flows. So this often happens with turns or lightening of sedation. This is often relative hypovolemia, but I want to caution you that just like in any other ICU patient, just because someone responds to fluids doesn't mean fluids are necessary. If as soon as you finish the turn, the person's flows immediately recover, giving unnecessary volume is bad. We know in ARDS, every unit of blood transfused increases bad outcomes. Unnecessary fluid increases worsening of the pulmonary function and prolongs time in the ECMO circuit. So if you can turn the patient, the flow's cut out, and then you rapidly recover within a couple minutes, even the brain can handle hypoxia for 2 or 3 minutes. And sometimes you can troubleshoot this with some ventilator mismanagement. Second problem becomes you have to slowly increase the RPMs, the diminishing flow returns. So we were at 3,800 RPMs yesterday. 2 days from now, we're up to 4,500 with the same flows. So what's going on? Is it hypovolemia? Again, we diurese these people aggressively to try to optimize their oxygenation. Drainage cannula obstruction. Has the cannula moved? Did it migrate into the hepatic vein? Is there thrombosis on the cannula? Again, check the oxygenator. You hit about a week plus out, you start worrying about oxygenator failure. And in about 2 weeks, all the oxygenators will start to fail. So we're thinking 10 to 14 days of ECMO runs, we're going to be doing some oxygenator changes. And this is often true. Finally, the pump can fail, but that's much less likely. The pump lifespan is much better than the oxygenator lifespan. Coagulopathy. These patients are usually on heparin infusions to prevent thrombosis formation. However, a lot of complications result from heparin infusion. So we use PTTs to measure anticoagulation. So over time, you may see an escalating dose of heparin. This could imply heparin resistance. At this institution, what you're going to do is check an anti-10A. If that's therapeutic, but your antithrombin 3 is low, then you're adequately heparinized. You just need more heparin than usual to achieve your heparinization level. This is like the type 2 diabetes of heparin. This doesn't mean a problem's happening, it just means you got to watch this because if you consume all your AT3 and have a full acquired AT3 deficiency, heparin will no longer work. So you could switch a different agent, replete the AT3, and most likely get hematology involved. The second problem that happens is bleeding and clotting, oozing from cannulas, clots in the circuit. Look at the platelets. Do you have HIT? Are you going to DIC? Or more likely you're getting septic? Well, another sign of sepsis in these patients is a weird clotting bleeding phenomenon from sepsis activation, the clotting cascade. We don't have real-time access to thromboelastography, so our ability to measure quantitative clotting rates on ECMO is limited, so we have to kind of use our best judgment. Some pearls of wisdom for when you're starting to initiate ECMO. All these patients are dry, right? Everyone with ARDS, what are you going to do? Dry them out. A liter and a half negative a day, right? ECMO studies for looking at ARDS, good outcomes in ARDS, dry that patient out. Dry lungs for happy lungs. So you often always need to give some fluid back initially. There's going to be some contact activation, manifests as vasodilation. This responds well to norepinephrine, little neo push. It's usually transient, but you don't want to be going in ECMO without any pressors in the room. Also, your drugs need to be rapidly titrated, so your carrier should be at a pretty high rate. I usually turn up to 150 or 300 mLs an hour. It's far easier to place lines prior to ECMO. If you're heading towards ECMO, get your central line in, get a radial A line in. Remember, we're going to want the right IJ and the right femoral, so think about a left IJ or a subclavian central line. Any cardiac concerns at all, consider putting a PA catheter in. These people aren't able to routinely do a point-of-care ultrasound. You got to gown up, bring the machine in the room, wipe it down, clean it over. That machine is used for everyone else in the ICU. We don't have a dedicated echo machine. If you're worried about the heart, a PA catheter may be your best bet. It's better to place the cannula too deep and withdraw them the other way around, just like any other line, right? It's safe to pull back, hard to push in. Low threshold for treating sepsis. We can't really swap the cannula or the central lines. So again, best practices lines, try to avoid drawing any labs off the central lines. Just use your A line, minimize connections and changes. And then any concerns, broad spectrum antibiotics, because you're not going to be able to come off these lines very quickly. It's a huge dog and pony show for someone who's VV ECMO dependent to recannulate them on a new circuit. And again, remember lastly, though, patient care is paramount. If you don't have a way to get anything other than red IJ in, put a red IJ in. We can double stick the red IJ. We did it a couple weeks ago. We can figure it out, all right? And when placing a femoral line, so let's say you're getting ready to prone the patient, you're like, we're gonna help out, we're gonna get a femoral line in now so we can easily exchange it for an ECMO cannula. That's great. I give you 2 pearls, all right, when placing femoral lines in our ultrasound. These are very large cannula, so they're not forgiving when you take them out down the road of any malposition. The picture on my left here shows a common femoral with the greater saphenous and a very large accessory anterior saphenous. The accessory saphenous is very small in most patients. If you were to cannulate that common femoral vein to the GSV, that's fine. You put a triple in the GSV. The issue becomes if your cannula goes right down the middle there, it's going to shear those 2 veins off of the common femoral. So when you pull that femoral cannula, you're going to get a huge hematoma and you're not going to know why. You're also going to get a lot of cannula oozing, which is going to be a lot of phone calls. And you may think, cannula oozing, we'll come and we'll put an extra purse string stitch in, we'll hold pressure. You're right, it's venous bleeding. We can deal with that. The problem is, this is again a patient with a high-risk thing where we're using masks that look like they're bought at Walmart, right? So we're running a situation where we're gonna be going in and out of that room multiple times to put sutures in, having multiple in and hold dressing changes. Probably not ideal. We're trying to minimize traffic, not have 16 people go in and out of that room. The picture on the right shows the ideal target location. You find your bifurcation of your femoral artery just above it to the common femoral vein. An advanced maneuver here is to keep scanning proximal until you see the vein start to dive away. Now you found the pelvic brim. Now that's the vein becoming the external iliac vein. That's not where you want to stick. Scan back up, find as close to the bifurcation as you can where the vein is still parallel to your probe so you know you're in the common femoral area. That's important because at this level, you're above roughly the femoral neck and you can easily apply pressure. Those of you who do pain medicine, those of you who have done time in the cath lab may say that's not always true and vessel anatomy can vary. Without fluoro, you don't know. You're correct, but in these patients, we're not going to have fluoroscopy. So you're going to have to rely on the ultrasound best practice. And talking to our interventional cardiologist, that's our recommendation. Find the bifurcation, scan up and down above it, try to identify where it dives to the external iliac location, and try to stick in a confident area where your needle is going to be in the common femoral vein. I also would say in these patients, these need clean sticks. This is probably not the time for someone who's like, I read about central lines once on the internet and I saw Jerome's talk. Maybe it's time for me to put the central line in. Finally, call early. Any questions, call us. We want the person on our radar. We have a whole protocol in place. You've got many emails about management in the ICU workflow around proning. I want to highlight the fact that our contraindications to ECMO, unfortunately, are more strict. But again, always call. It's MGH. We'll evaluate each patient on a case-by-case basis. But I want you guys to be aware that we're going to be stricter than we usually are in ECMO because you need to conserve circuits and beds. And it seems like with such a prolonged recovery time, someone in ECMO is probably buying themselves close to a month in the ICU minimum, even with a good recovery. That's a pretty valuable bed to use. So we're going to be pretty strict on picking patients who have a high chance of recovery. We also have pretty limited data now on how these people do with ECMO, unlike H1N1. So it remains to be seen. This is a moving target. We may find out from Iran, China, and Washington, we're a little ahead of us, what their best practices have been, who's a good ECMO candidate, any other predictors of disease progression that may let us know this person is or isn't a good ECMO candidate. That's the talk for now. I'm to open it up for questions. I think you guys can unmute yourselves. I'm to unmute. No, I think you can unmute everyone. Let's see what happens. Feel free to ask questions if you can. All right, I'm gonna unmute everybody. Free for all. Any questions? Or you got back to work?
Hey, Jerome.
Yes, Jenna.
Is it consult team?
Jenna, I'm losing you there.
Maybe type it into the chat.
Yeah, might be able to see a little bit better. I'm trying to see the.
Hey Jay, while Jenna's typing in her question, there's been talk about using PEEP to try and reduce cardiac output to better match ECMO flows?
Yeah, so again, the same idea, dropping venous return to the heart to reduce the cardiac output could be effective. The question's going to be, Alex, is if your cannula position is such that you're also dropping venous return to the drainage cannula, you may also drop your ECMO flows as well. So it's certainly worth trying. It's a pretty benign intervention. I think the other thing I'd be careful of is significant amounts of PEEP to causing a lot of over-distension ARDS. I'd be worried. One thing we are seeing on these people who are seeming to recover is what's the best practice is just really, really good ICU management of ARDS. Far more important than ECMO. This does not seem to be an ECMO illness right now. It seems to be proning early, low tidal volumes, daily best PEEP trials. People's lung compliance is going up and down, optimizing recruitment. And we've seen people seem to be getting ready to go on ECMO. We do a little testing with the vent, and then we turn around, they're back down to 30%, PDEFs up in the 220s. So as intensivists, it's again, just really good ARDS management seems to be the important part. Jenna's question, for those of you who didn't see it, is does the ECMO app still work? It does. The Heart Center phone is still live. It has not been updated with the COVID stuff because the company that makes the app is a little slow to work, but call it. We have it 24/7. Someone's always available. We have people able to cannulate the patient pretty quickly. We're trying to avoid doing any kind of ECPR, emergent cannulation. So pulmonologists, everyone's on kind of board. Every morning we run the list. We're frequently checking in, making sure people's FiO2 is not sliding. But please, any questions, feel free to call. Any other questions, guys? I know we've gone over time.
This is slightly off topic, but are they proning people at a P to F of 150, or I heard they're getting a little more aggressive with that?
So my experience has been talking to Peggy Lai and those of you in Blade 12 working with her is it's almost becoming a point that anyone who's having progression of ARDS, even if their PF hasn't hit 150, is early proning, with the thought being that maximizing the benefit, put them down 16 hours down, minimize the oxygenation, keep the lungs nice and inflated, try to minimize that posterior and peripheral lung injury. Again, we don't know the answer, right? It may be a situation where we learn that we need to prone even quicker, ECMO even quicker. We just don't know. But we're going off what we know for other cases of ARDS. And I think because we have stuck in a situation where once you really start to slide, you got to think about ECMO, we want to prove that proning is not helpful. And so I think early proning's there. I will also say somewhat selfishly, the benefit of early proning is we've gotten a lot of our nursing staff up in Ellison 9 and Blake 12 now very quickly, much more comfortable with proning, which I think will help us quite a bit during this era. We had a unit upstairs that hadn't proned someone in a long time, and they've proned 2 people already, and one guy's getting proned again right now, and a nice job. Brittany asked, are we sending our ECMO team to other hospitals? At the moment, we're only staying in-house. There is a hospital in the New England area that is doing remote cannulation. I think the problem is in this current era of needing to conserve circuits, we're at the moment trying to minimize that and keep our ECMO team in-house. I also will say in the state of Massachusetts, it's very, very difficult to rapidly get cannulation privileges at another hospital and to transport that. We just don't have an infrastructure for that really anywhere in Massachusetts to do that. I know New York does that, and there's some places in Connecticut that do that. And it may be something that we come down to, particularly if we find that ECMO really is a panacea for this condition. But I think the combo of not seeing that benefit from ECMO yet for resting the lungs and the logistical challenges and limited resources, we haven't been doing that.
Jerome, how many ECMO circuits do we have available?
So it's a moving target. I think we have up to 22 ECMO circuits. Ideally, we wouldn't have that many people on ECMO at one time. We have to save a couple for backup in case of circuit failure. We have to save 1 or 2 for our backup on our cardiac patients, right? People are still gonna be having MIs. And so people are still need support for VA ECMO for heart transplant. And so while, we scale back things, we want to do, we call it good ECMO. So the best candidates. So you bring me a 58-year-old male who has left main disease, needs to go to the cath lab for a stent. He's a pretty good ECMO candidate, even though he doesn't have coronavirus. So I need to have a circuit ready for someone like that too. Ken wanted to say something here at the end before I let you go. Ken, you there?
Jay, are you still there?
Yeah, we're all here. What's up, Ken?
Good. No, I just want to say I think it's incredible, Jay, what you've done. I want everyone to kind of appreciate the hard work Jay is put in both to this lecture, but also to kind of making sure that we have a connection with all of the patients in the hospital that are on ECMO. One thing that we'll start forwarding, Jay, every day is a list of all of the number of circuits that we have and the number of patients that we have. And my hope is that Jay can kind of be the person to, with these consults, decide which of these patients would be appropriate patients. I think one of the things that Jay did show, the new absolute contraindication list for COVID patients is a little bit different. So the age cutoff is 60. And so that's certainly different. And again, as Jay mentioned, the plan will not to be doing eCPR. So those are kind of big changes from ECMO pre-COVID. And I still think, though, it's important to, as Jay pointed out, call every time, and then we can make a decision as a group in terms of the best patient to put on. Thanks, Jay.
Yeah,
thanks for everything you've done.
Thanks, Ken. Appreciate that. And I just want to say also a shout out to Ken, Yuval, and Misaki, who've been working kind of around the clock here, revamping our ECMO team and having what I can only imagine is some very tiring meetings, a lot of administrators making sure everything's supported. We have all the equipment we need, as well as working, and Ken's still doing a full clinical load. So really appreciate that to Ken. Last question I'll answer real quick from Brittany is, has there been a typical amount of time or days for patients going from intubation to ECMO? And that's, again, been very variable. It's been more of a sign of rapid progression. I will say the patient we cannulated, who's treading water on ECMO, he's needing full ECMO support. When we cannulated him, his SAT was 88 to 92 on full vent support. So again, we weren't falling apart. We did it somewhat electively, which is our goal. Unfortunately, I think I wish I had a crystal ball and call the future intensives from next year to know, Brittany, what we'll know. Like, I think that 12 months from now, we'll have a much better idea on the rate of ECMO deterioration, the rate of need of ECMO. We don't yet. We have one person on the circuit right now. We have a couple more in the wings, but so far the pulmonologist has done a fantastic, incredible job with ECMO management, pre-ECMO management, to be able to turn them around. And it's just kind of prolonged vent management. So we'll see what's going on. I will say it's been impressive how rapidly the hypoxia sets in. People will come in on 1 liter nasal cannula, they come to you intubated. Next day they're prone. 2 days later they're on ECMO. That's been rare. Only one so far. So fingers crossed, everyone out there is going to stay safe. All right, guys, if there's no other questions, I'll let everyone get back to work. I got to go around. Thanks again to Ken in particular for helping and put together all our protocols, as well as covering Blake 8 while having to go through 100,000 meetings. I can't even imagine. And I'm sure dealing with a drowning level of emails. So thanks, Ken, and thanks all you guys.